As a valued NEI podcast listener, get $100 off NEI Fall Congress registration with code POD26. That's POD26. Go to nei.global/fall, FALL, to sign up today.
Welcome to the NEI Podcast. On this show, psychiatrist, psychopharmacologist, and chief medical officer of NEI, Dr. Andrew Cutler, sits with renowned mental health experts from a range of backgrounds to discuss breakthroughs and best practices for treating patients with mental health conditions.
Hello and welcome to another NEI Podcast. I'm Dr. Andy Cutler, and with me today is one of my really close friends that I've been working with for many years, and we're going to be talking about something that we've been talking about for quite some time now. This is Dr. Roger McIntyre. Roger, how are you?
Hey, Andy. Great to do this together. Of course, it's been so wonderful having this knowledge journey together for decades.
It really has been. Well, Roger, before we get into the GLP-1s, which of course is the star of the show, I want to ask you a little bit. You've had quite a long career in a field that I guess we could best call metabolic psychiatry. Could you tell us a little bit about what that means and kind of how we should think about it before we jump into how GLP-1s might fit?
Yeah, happy to, Andy. And you're right. I think that metabolic psychiatry is had a bit more, I guess, street lights been shining on it lately. And it really, in fact, I suppose comes down to who you talk to. I suppose there's more than one definition. A good friend of mine, I'm sure you know well, scholar extraordinaire, Natalie Rascon, at the time was at Stanford. She's now, in fact, professor emeritus. Natalie's a good personal friend, wonderful person, smart as heck. And I remember decades ago, we met, as often these things are, Andy, just like you and I met at different conferences, and her and I were chatting. Natalie has been a scholar in the area of metabolism, the brain, aspects of brain health and disease. And at the time, to be quite frankly, it was a lonely place. Other than Natalie and I, we didn't know many of people were doing this kind of work. We convinced ourselves that it was important, but I guess we didn't clue in that we were the only ones thinking that way. But anyways, nonetheless, I think for us, the way we had conceptualized it then and now is that when we step back, we look at this brain, the central nervous system in the human being, that the health of that brain, the disease of that brain, depends on or is influenced by, respectively, changes in metabolic systems. What does that actually mean? Well, we've talked about for decades, Andy, as you know, disturbance in monoaminergic systems, and of course, that's been a prevailing view. It's been augmented recently with other paradigms like GABA, glutamate, and others. But the essence, if you will, of the metabolic psychiatry we saw was that in the brain at the cellular level, you are seeing alterations in molecular and cellular function that are a consequence of a perturbation in either peptides and proteins relevant to metabolism and or organelles relevant to metabolism. Of course, the first one that comes to mind always is the mitochondria. But we focused more in those days on insulin, and both working on insulin, and we took an interest in related peptides. And really, to summarize a 35-year story, more recently we did land on GLP-1s. And I suppose in many ways, to refer to GLP-1s as metabolic drugs would not be inaccurate. That's probably how they're best known, but that would probably not do justice to what they're actually doing to their brain, because many of their effects on the brain are not really sort of narrowly defined metabolic. They're directly affecting, for example, glutamate and so on. So metabolic psychiatry is a concept that Natalie and I talked about decades ago, where we really were convinced that there's something that could be of explanatory value in explaining the pathophysiology of mental illness related to metabolism. And from that, the derivation was maybe innovative therapeutics, repurposed drugs that currently exist, or developing new therapeutics could help brain disease, broadly defined, by targeting these systems.
Yeah, well said. It must have been a little lonely being that far ahead of the curve, Roger. Sometimes it's a little lonely there.
Well, it wasn't. I remember, Andy, that, as you know, I mean, in academia, it's kind of feast and famine, and you kind of live and die by getting grants. And I think everyone knows that. And I took an interest in this, not for any other reason than just clinically, I was seeing patients and I was always curious about why it was that in depression and bipolar disorder, when patients did have concurrent obesity or concurrent type 2 diabetes, of course, which is very common, those patients, at least as I sat and watched them, appeared to have much more difficulties cognitively and more difficulties in the area of what we would call generally anhedonia. And by the way, Andy, congrats on that great paper you led on anhedonia. This is a kind of a state of the union on anhedonia that Andy led on many of our behalf. So thank you for that. People should get a copy of that. And so on cognition, I just started thinking about it. I got to say, certainly the first 5, I might even say 7 years, I was kind of broke, as I wasn't very successful with my grant writing. I was getting good idea, but 0, or good idea, we're going to write this bottom of the heap. And
Yeah.
I guess, anyways, that's then, this is
Yeah.
now. Things have changed.
Yeah. Well, I guess an attaboy and a nice warm handshake isn't as good as getting funded, getting grants. But Rogers, you well know, I trained in both internal medicine and psychiatry because I was struck way back then also about the connection between the brain and the body. And I sort of saw psychiatry as like internal medicine where our organ is the brain. And so you and I were sort of parallel in that kind of thinking. And, since then we've really learned a lot about that interaction. I was struck just thinking about monoamines, about how, serotonin and dopamine, norepinephrine are not just in the brain, they are all through the body, the nervous system connects. I was very interested in neuroimmunology, things like that as well. And it's kind of nice, like you said, to see kind of something come to fruition.
Yeah.
You mentioned the GLP-1s being repurposed. That's another thing, sort of an interest that you and I share, is this idea of repurposing medications. And I guess, a really rough thing that comes to mind our audience might resonate with is the fact that do you remember the paradigm shift? I'm sure you remember in the early 2000s when we found, oh my God, these drugs called antipsychotics are also mood drugs. And the SSRIs not only treat depression, but anxiety. So,
Yes.
we have to sort of get out of our little cubby holes sometimes when we think about these things. Well, let's talk about GLP-1 receptor agonists, and maybe we should start with the GLP-1 receptor, which is not just peripheral, Roger. You've talked a lot about also centrally, and so perhaps these drugs are working both peripherally and centrally, but maybe tell us a little bit about that.
Yeah, of course. And the GLP-1 receptor, of course, is if there's a lock and key, if that's the metaphor, this would be the lock, the key, of course, being the GLP-1 ligand, the agonist, which is naturally produced but mimicked by pharmaceutical agents. And the receptor itself is best known as a G protein coupled receptor, very common GPCR type, target. And what is really interesting with the G protein coupled receptor, GLP-1 receptor, it's excitatory. So it's maybe finish the descriptions, GPCR, it's excitatory. It generally is a postsynaptic receptor and is generally found, it's certainly found on GLP-1 protein producing neurons, but it's certainly found on other neurons, which is really relevant to the translation of why they might be interesting from a psychiatry perspective. For example, they are found on GABA neurons in the striatum. They're found on glutamate neurons. So there's that excitation inhibition. You can find them on other systems as well throughout the brain. In fact, we know the orexin system is involved in arousal, and there's a bit of a crosstalk between GLP-1 orexin. By the way, Andy, you know this, orexins are also known as hypocretins, and hypocretin, it's a portmanteau, kind of a combination of two words of hypothalamically derived secretin. And as you know, orexin modulators are being developed for depression. They also have a favorable effect on glucoinsulin homeostasis. So the G protein coupled receptor, the GLP-1 receptor, where is it? Well, it's interesting because we know that location can tell us a lot about something, and topographically they're distributed in many parts of the brain, but where they're really, not surprising, they're found in the hypothalamus that regulates our appetite. But those receptors are also found in other parts of the brain that are kind of raise interesting questions about psychiatry. For example, they're found in the hippocampus. We know the hippocampus is relevant to memory. They're found in a part of the brain known as the septum, and many people may not be as familiar with the septum, but the septum's involved with a number of aspects, including anxiety, but also, threat, things like that, and maybe reward. And we also, in fact, know that they're located in the amygdala. We know what that plays a role. And they're also found in the cortex. We're already starting to sort of map out at least a rationale why they might be integral to normal brain function, E.G. cognition, motivation, reward, things like that. So that was really an interesting observation, finding out where they were located.
Well, of course, yeah, you're talking about cognition, mood regulation, motivation, reward, links to orexin would be arousal systems,
Yeah.
circadian rhythm. There's a lot there. Yeah, and also you've also talked about how they seem to crosstalk and link with NMDA receptors, glutamate and NMDA receptors.
They really do, and it's really interesting because I actually was working with one of my PhD students who she's been working with me. We're working on a project right now. We're looking at the crosstalk between the glutamate ionotropic receptor, specifically NMDA AMPA, and the crosstalk with insulin receptor and GLP-1. And for many that this just to bring this together, I think that many I've been hearing lately that the NMDA receptor, the AMPA receptor, they kind of work in tandem together, and they're sort of joined at the hip, so to speak. And whenever you have modulation of NMDA, you sort of engage AMPA. And for those who are sitting their board exams, if the question said, which receptor of the glutamate receptor ionotropic class is most relevant to plasticity, and most is in big, big font, to plasticity trophism, because all the receptors are relevant, but the ones most would be the AMPA, actually. And what's interesting is that we have a biomarker of synaptic strength is the ratio of NMDA to AMPA. The more AMPA you bring to the surface, the stronger the attachment between the neurons that fire together, wire together. And we know that ketamine, esketamine, dextromethorphan type drugs do that. Then we discovered so do GLP-1s. And it turns out that GLP-1s also bring AMPA to the surface. We did a study, colleagues of mine in South Korea and our group in Toronto, where we took rodents, we stressed them, we gave them liraglutide, one of the GLP-1s, and it protected the brain against against loss of BDNF, but also protected the animal against behavioral despair. When we knocked out the AMPA receptor, the glutamate receptor, liraglutide didn't seem to work. So that's to say that the GLP-1 is doing something about AMPA trafficking to the dendritic membrane. And we wrote a paper about a year or two ago talking about the functional and anatomical crosstalk of NMDA, AMPA, insulin, and GLP-1. And they're all involved in plasticity and trophism and so on. So Mother Nature's got this orchestrated that they are sort of joined at the hip.
That's fascinating. Well, you've also talked for years about insulin regulation in the brain and the insulin receptor, if you will. So it stands to reason that modulating and maybe even normalizing glucose regulation is good for the brain. There's even, of course, theories around dementia, Alzheimer's dementia, and glucose dysregulation. Some people have called it diabetes type 3. I think you refer to it that way sometimes.
Right.
But let's talk a little bit more about these GLP-1s. So great theory, Dr. McIntyre, but what's the evidence? What's the evidence that these drugs might help psychiatric conditions? And I guess the best evidence would be for mood disorders, depression, cognition. We know certain substance abuse issues, alcohol, opioid, smoking cessation. But what evidence do we have that we might be onto something here?
Yeah, absolutely. Just to sort of maybe kind of just frame this, many would know there's a pyramid of evidence. There's different tiers of sort of rigor and translational value. There's also different types of research, and they kind of complement. So there really has been a confluence, whether that be mechanistic research in a laboratory, animal research, but also moving over to the human being world, whether they be observational studies. There's what's called Mendelian randomization. The list goes on and on. There's target trial emulation. At the end of the day, it comes down to clinical trials. And the clinical trials still occupy the apex of our evidentiary pyramid. And I would say that we have some data and we have some what's called, adequate and well-controlled studies, especially in the area you alluded to, Annie, in the area of alcohol use disorder. So if I was to sort of maybe step back and just arbitrarily think about psychiatry as this, remember this sort of mental, neurologic, and substance use disorder was the WHO used for years. If we use that typology, the substance use disorder category, specifically alcohol, is, I would say, supported by the most rigorous evidence right now. That is adequate, well-controlled, double-blind, placebo-controlled studies documenting in people with AUD, alcohol use disorder, a significant reduction in heavy drinking days and number of drinking. Now, days. Now, many people would say, well, where does that fit in against disulfiram, naltrexone, or acamprosate? Well, those drugs don't decrease heavy drinking days. Those drugs have other effects, but they don't decrease heavy drinking days. And as you know, Andy, the FDA has moved, it's sort of evolved in how it's thought about this, and achieving abstinence is not considered the endpoint anymore. It's called harm reduction. And what you're seeing is not so much abstinence, you're seeing harm reduction with these agents, along with, you kind of get a 2-for-1 deal. A lot of people smoke cigarettes as they're having a drink. It's almost, it's like almost like a Pavlovian kind of conditioning. And they also reduce the smoking in these people as well. And to give you a little cherry on top, so to speak, it's protecting your liver. So the alcohol part's really intriguing. On the neurologic side, specifically Parkinson's and Alzheimer's disease, Andy, you and I both know those are difficult conditions to treat. And if the perfect medicine fell down from heaven this afternoon and we studied it in Alzheimer's disease, its batting average is not going to be very high. It's just the nature of treating Alzheimer's disease in clinical research, and you know that better than anybody else. So the results are a bit mixed. In Parkinson's disease, there are very rigorous studies, randomized, double-blind, placebo-controlled with GLP-1s, especially exenatide, looking at that drug, showing some benefit on motoric symptoms. For example, loss of, worsening of motoric impairment. It's mixed. And we're also sort of in this kind of uninterpretable land. Alzheimer's disease, there was a recent readout, a 2-year study called Evoke Plus with semaglutide oral, where it didn't beat placebo and trying to decelerate cognitive impairment in people who were amyloid positive early AD. We're a bit perplexed because there's another study almost published the same month showing that there was a benefit in a different randomized double-blind placebo-controlled trial. So, it's sort of hard to know. And then we move into schizophrenia, bipolar disorder, depression. As you know, we've just launched, there's a compound called brenipatide, which is a GLP, they call them double Gs, GLP, a bit like tirzepatide. It's a bit like that, but different. And it has now entered into pivotal, meaning seeking an FDA authorization, pivotal, randomized, double-blind, controlled studies in schizophrenia, bipolar disorder, depression, and opioid use. But on the first three, it's interesting, Andy, because in the schizophrenia, bipolar depression population, these are not acute studies. These are studies where patients are stabilized on SOC, standard of care, then they're randomly assigned to get an adjunctive placebo or adjunctive GLP-1. And the primary question is preventing relapse in time to that event, of course. So to summarize, I would say we have a lot of preclinical, a lot of mechanistic, a lot of observational data. All lines are leading to the same promised land. We do have a lot fewer RCTs, and I would say, who knows where the future is going to go, but alcohol probably has the lead in terms of consistently getting a big effect size.
Yeah. Well, you're talking about Eli Lilly right now is doing a whole suite of these studies, and I believe that's what you're referring to. And I think alcohol is the farthest along. And it stands to reason. I mean, we've talked mechanistically, there's preclinical evidence. But if you're modulating motivation, reward, and appetite, it seems you would be also modulating appetite for other things, such as alcohol and perhaps nicotine and so on. And so, again, there's a lot of reason to believe, if you will, but we do have to prove it. And as you know, I mean, that's what I've spent my career doing. Clinical trials are tough. They're fickle in a way, and there's failed studies, even with drugs that we know can be effective. So sometimes it's methodologic issues. Sometimes it's the fact that our conditions are very heterogeneous, Roger, and we're not really good at biomarkers, at matching maybe the subtype of people who have the real neurobiologic substrate, if you will, that's really going to work for this drug. So, hope springs eternal here.
Yeah, the point you just reminded me of there is, as you know, when a study does not meet its pre-specified primary endpoint, we pound the table, we say the drug doesn't work, the heck with it. That could be true. It could also be true that something went wrong with the study. We know this firsthand. And one of the aspects about the GLP-1, at least the subcutaneous peptide type drugs, is this still uncertain answer to the question, do they get into the brain? And, right? And so for example, the Alzheimer's work that Novo Nordisk did, the Evoke Plus trials in Alzheimer's disease, they looked at phosphorylated tau P181, and that's a biomarker of the disease and clearly a biomarker of how much CNS penetration you're getting. And there was a little less effect on the marker, and so that raised questions whether there's adequate penetration. My friend Natalie Rascon just published a study using neuronally derived extracellular vesicles. These are vesicles that are derived from the brain in people who had received liraglutide, and they showed effects. So that suggests it's getting into the brain. That's our work too. So many would know listening that there's a new type of non-peptide GLP-1s. This is orforglipron, the so-called gliprons. And those are interesting because they're a heck of a lot smaller. And the question is raised as to whether those drugs might be better able to get into the brain. That's a hypothesis, but that's a question being raised. Remember the smaller proteins, because they have a lower molecular weight. Part of this is just physics. You can't put a tractor trailer through a tiny little door. And so that's an open question too.
Roger, that's a really interesting point because, as you know better than anybody, there are dozens, if not more, of these drugs in development, and they're not all the same. I mean, there's a lot of differences here. You mentioned one, they may be GLP-1 agonists, but then they can also have GIP, they can have glucagon. Yep. Something you had talked to me about earlier, too, is they can be an agonist, an antagonist, a partial agonist. So yes. There's a lot of different ways to slice this, and now you're getting me to think that maybe there's differences in getting into the brain amongst these different compounds, and as you said, peptide versus non-peptide. So, it's possible some of these are going to work better than others for psychiatric and neurologic conditions, so we have to, wait and see.
Are you looking to stay current in psychopharmacology without falling behind? Well, NEI membership gives you on-demand access to expert-led education, practical clinical tools, and resources you can use right away. From master psychopharmacology content to patient education materials and CME opportunities, it's all in one place. Join thousands of clinicians who rely on NEI to sharpen their skills and improve patient care. Learn more at NEIglobal.com.
You mentioned something else when you talked about the substance abuse, alcohol in particular. years ago, Roger, I did an alcohol abuse study with samidorphan, which is a potent opioid receptor antagonist. Some people may know it as part of the combination, the olanzapine-samidorphan combination, commercially called Lybalvi. And back then, you are right, the FDA's primary outcome measure was total abstinence, which I agree with you in the short term is not reasonable. And what we found was it did not separate from placebo in total abstinence, but it separated on every other secondary measure. Days drinking, problem drinking, binge drinking, and so on. But it didn't get approved there. But the FDA has moved forward and changed so that you're right. Now that no longer is that the expectation. And I totally agree with you. Harm reduction is a much more reasonable expectation in the short term, and abstinence maybe in the longer term. It's sort of a process to get there, I would think. But it raises the point that sometimes regulatory issues are involved here as far as what the endpoints the FDA will accept. So that's something else to consider. But let's talk for a second, too, about this idea of peripheral versus central. I mean, clearly, if nothing else, peripherally we know it's good to lose fat and to lose weight. We
Yeah.
know that's good for the brain. We know you decrease inflammation and so on. We know if you improve glucose regulation. So if nothing else, that has to be a good thing. You've certainly talked for years about weight loss by any means is an antidepressant. Weight loss by any means is good for cognition. What do you think about this, about where the effects are and how to balance this, or should we even worry about that?
It's something I've been thinking about for so long. So it's something that I'm not sure if I think about it any longer. I'm more clear on this, but I think that just so everyone, has a similar line of sight that we have. I mean, it's, I think, intuitive that if you're developing a drug for the brain, the drug should get into the brain. So this is common sense. And at the same time, there's many drugs that don't really get into the brain that seem to have really therapeutic effects on the brain. And for example, give a gigantic monoclonal antibody to treat Crohn's disease, ulcerative colitis, and psoriasis. They don't really get into the brain very well, but they clearly have great effects. They improve, they reduce anhedonia, they improve depressive symptom severity. And that's probably indirect, right? So they get less inflammation, other factors, whereas this can go across the blood-brain barrier. My own instinct about this is, I still think that we want to get into the brain. I think indirect matters clearly. And a lot of the effects of GLP-1 is indirect through anti-inflammatory, antioxidant effects, improving insulin resistance. But we do, just so everyone's clear, there are lines of evidence that we are getting penetration with some of these drugs into the brain. It may not be a lot. The other part is although we talk about the blood-brain barrier as this sort of, Teflon, nothing's getting past it. The fact is there are areas of the brain that are accessible around the ventricles and so on. And so one thought is maybe you don't need to have deep penetration. Maybe as you get to some of these key regions, and people are thinking that way as well. So I think for me, at least in the discovery and the development side, I still think we want to get good CNS penetration. That's why I'm a bit more intrigued by the Rextins. These are the Glipron. The Gliprons are the orforglipron, which is a non-peptide. They're oral. You don't need you don't need a cold chain supply. You don't need to actually have cold storage. You don't need to have the fasting requirements and all that. But on top of all that practical stuff, they are smaller, and because they're so small, you have a better chance of getting it to penetrate the brain. And so that's something to me, is that from where I would place my bet, that is certainly something that catches my eye.
Yeah. Well, you just made me think of something else too, and this gets to our point about the heterogeneity of our illnesses. With stress and inflammation, the blood-brain barrier also becomes a little more porous. And so perhaps for subtypes of people that have more, certainly trauma history, stress, inflammation, it's possible you're getting, it's not just one size fits all with brain penetration. So that's another thing to consider. I'm also struck by how these drugs have multiple indications now. So for instance, semaglutide is even approved for sleep apnea of all things. So losing weight maybe improves sleep, and we know that's good for the brain. So there's all kinds of avenues. They're cardioprotective, they're renal protective. And the one that you taught me about, which blew my mind, was the positive effects on the liver, the beneficial effects on fatty liver, for instance. It's quite remarkable what these drugs can do. So I'm excited too if some of them can get some of these indications. And let's just stop, for instance, with alcohol or smoking. How many of our patients use alcohol and smoking? Because a concern I hear is, well, I can't get these drugs paid for. Well, if they get those indications, maybe you're not going to get them approved for depression or schizophrenia, but certainly the comorbidities that we see. So my point is that our audience needs to become conversant with GLP-1s is really, and I know you agree with that.
For sure.
You mentioned something else about schizophrenia. My understanding is that Lilly's also doing a study on cognition in schizophrenia, which, as we know, is one of the holy grails of schizophrenia, negative symptoms and cognition. So If they help, of course, prevent psychotic relapse, that would be fantastic. But if they also can help a little with cognition, that would be pretty amazing too. Now, I know you've been very involved with the depression and bipolar, and I think you said these are not acute antidepressants. However,
Right.
they may help with relapse prevention. And this brings up the concept you and I've talked about before. Maybe we should think about psychiatry treatment a little like we do, say, cancer chemotherapy, kind of an induction treatment and then a maintenance treatment.
Yes.
And maybe they're not exactly the same. So, for instance, something like ketamine might get you better quickly, and then you could use something like this for maintenance. What do you think about that kind of model?
Yep, I think that's a model we have to think about. We should think about. There's so many examples in medicine where the acute treatment and the maintenance treatment or the preventative treatment, or whatever we're going to call it, they may not be identical drop-down menu of options. And there's reasons why, because the mechanisms that are getting you well may not be identical to the mechanisms that are keeping you well, so to speak. And again, there's many examples, migraine, there's many others. And so when it comes to bipolar, major depression, and schizophrenia, I have to sort of preface by saying I stand corrected, but I only know of one example, that's being lamotrigine, where a treatment the FDA is approved for maintenance, they didn't approve for acute. And that's part of this way we've done things for decades in psychiatry, where treatments are acutely shown to be effective. Then we move on to maintenance. But what's interesting is that, see, you can learn a lot from other areas of a kind of a cross-disciplinary translational way. So diabetics have three related cognitive problems. First, they have cognitive problems as part of being diabetic and the insulin dysregulation, inflammation. Secondly, they have progressive cognitive problems. And thirdly, a higher rate of major neurocognitive disorders. And what's interesting is that there was a very important study conceptually called the REWIND trial with dulaglutide, a multi-year study done in diabetics, and they're a little older, and they of course captured metabolic measures, but they also captured the famous, MOCA, but they also captured a version of the DSST type test. All to say that the patients who received the GLP-1 over time had a deceleration of cognitive loss. Now, this was in part what provided the impetus to do studies in Alzheimer's and Parkinson's, and we talked about the data are mixed, but the effects of GLP-1s, even after you get to an adequate dose, if they are affecting, plasticity, trophic processes, that might happen more acutely, and that's relevant. But some of these processes might take a bit longer, and I think many would know the longer you stay on a GLP-1, the more weight you lose out to 6 months, even 12 months. I've often said this, Andy, that obesity in many ways is like the hemoglobin A1C of your brain. And so when you see that trajectory, knowing how the body is so badly trying to adapt to this weight loss, they keep losing the weight. And that tells you there's something about a disease modification effect going on over time, even a greater effect. So the brenipatide trials we referenced, the Eli Lilly trials, this is the GIP-GLP agonist, a bit like a tirzepatide, but slightly different. That program is entirely relapse prevention. It's not acute schizophrenia, it's not acute mania, it's not acute depression. It instead is adding to the SOC standard of care in people who've already stabilized on conventional treatment. Then they're randomly assigned to placebo or the brenipatide to see the time to relapse and things like that.
Fascinating. I talked a little bit about use of these drugs in our patients, and we alluded to the fact that the association with obesity and diabetes and cardiovascular disease is very high. And weight gain is a possibility with our medicine. So could we think about GLP-1s for helping with taking weight off or preventing weight gain with some of our antipsychotics?
I would say at this point, the GLP-1 agents as a class could make the claim of being the best studied, most rigorous, most compelling effect size improvement in anthropometrics and select metabolic parameters in that scenario. Patients taking antipsychotics, notably clozapine and olanzapine. Some studies now with semaglutide. There's also been work with exenatide. but some very rigorous studies showing that in people who have schizophrenia or schizophrenia type spectrum disorders, who are taking one of these GLP-1s and they're being treated with clozapine or olanzapine, which we know to be two of the most offending agents on weight and metabolism, and a significant improvement. Just to kind of benchmark this, metformin's become sort of a popular go-to in psychiatry for this purpose, as you know, Andy. And there's two paradigms, primary prevention and secondary prevention, which primary prevention, metformin does better than secondary prevention. But even in primary prevention, the placebo-subtracted difference is around 3 to 4 kilos. Not bad, not bad. The difference with the GLP-1s is between 10 to 20 kilos. I mean, it's not even close. And you get additional benefits in other areas as well. So I think if quantity of studies, there's more metformin RCTs for sure. But in terms of the quality, what's there with GLP-1s is not inferior, and what the readout is just apples and oranges better. And as you alluded to, the psychiatric population is differentially affected by many conditions wherein the FDA has already approved GLP-1s for. The GLP-1s has been approved, not all of them, but each one's different, for 6 different indications, all of which are more common in our patients. So I would say that in most clinics, let's say these drugs were free of charge as much as you want, I would say, Andy, that without even hesitating, at least 75% of the patients that I would see in my clinic would be on one and be on label with one of these medications.
Right. Yeah, I agree. Yeah, you alluded to metformin. The metformin, though, you kind of have to start concurrently. It's better at, as you said, kind of preventing weight gain than taking it off. But the GLP-1s can do both. So
that's right.
Yeah, I think, again, to my thesis that our audience and mental health providers must become conversant with these drugs over the coming years. Now, I think we have to balance out our enthusiasm here and our excitement with some of the safety issues. And
yes.
So what are some of the things someone should be monitoring or concerned about here to just balance out the efficacy and safety?
A couple of aspects to keep in mind. As you know, Andy, a couple of years ago, reports came out of Iceland reporting suicidality in association with GLP-1 exposure. That story is now 3 years old. That story has been rigorously investigated by many different regulators, the European FDA, called the EMA, the FDA, the UK regulator, others. There is a consensus. All the regulators say, despite association, there's no causation. And their interpretation, which I certainly would agree with, is that people receiving these drugs who report suicidality, that suicidality might be better explained by concurrent mental illness. So that's not to say we take our eye off this issue. It's obviously it's reassuring, but it's not something I would say we just simply forget about, because clearly patients are at higher risk of suicide who take these medications by virtue of mental illness. The second one I might say, Andy, is that, like everything else in life, it's almost sounding too good to be true. They treat everything, for goodness sake. Well, no, they don't. And I think there's a couple of psychiatric disorders I would tread very carefully on. Anorexia nervosa comes to mind. In fact, a recent study published in JAMA Psychiatry reported that about 30 to 35% of people with anorexia nervosa or related eating disorders are taking GLP-1s. I can imagine if you have anorexia nervosa, GLP-1s is like a Christmas gift every day for you. This is probably very concerning in terms of the huge weight loss that's happening and so on. And some are taking it for binge eating disorder, things like that. So that's one. Another one is obsessive compulsive disorder. There was some, I can't say that we're the verdict's in on this yet, but there were some studies that came back using this trial design called Mendelian randomization, hinting that OCD might be a little exacerbated by these. I don't know. I would leave it as a kind of an observation for now, but that's still in the back of my mind. With respect to other aspects, Andy, just these are not contraindications, but just aspects that practitioners should keep in mind. Everyone knows, I think, that GLP-1s slow the gut motility, and we in psychiatry are world famous for giving out lots of anticholinergic drugs or drugs that have anticholinergic properties. So you could get some interaction there. Just be aware of that. Thirdly, just by virtue of malnutrition, people with substance use, schizophrenia, other conditions are often more susceptible to so-called sarcopenia, which is muscle loss with loss of function. In some very susceptible people, because about 40% of the loss of weight on GLP-1s is muscle, that can sometimes obviously be a bit more of a problem in someone who's at risk of sarcopenia. We give ketamine a lot for TRD, treatment-resistant depression. We tend to hold the GLP-1s for about a week beforehand because of the risk of aspiration, and that's recommended by many anesthesia organizations. Be aware of that. I think one other aspect to keep in mind, Andy, is the lithium-treated patient. Because people who take lithiums don't eat as much, they often don't drink as much, and because they're not drinking as much, their volume depleted. Lithium, as you know, already causes polyuria, and then when you start losing muscle, what's happening is that lithium in the muscle is going into the blood, the plasma, and that could jack up your lithium levels. So I think one needs to make sure patients are very well hydrated. And then finally, what I might say, it's sort of not quite a psychiatry issue, but it sort of is that, because of the cost of entry to get these drugs, people are going online using these compounders and so on. And when you do that, well, first of all, we don't even know what you're even getting. And second of all, there's a higher chance of medication errors, dosing errors, and overdose. And we did a study and we showed that what's interesting is that people who are more economically insecure and precarious, they're more likely to use this route of access and more likely to accidentally overdose. That's not the same thing as suicide. Again, because they're more likely to get poor quality product, or God knows what they're getting, to be frank, and also more likely to have these treatments that they're self-administering and they're not even calibrated and so on. So it's not really a psychiatry issue, but it certainly it's in our patients. So those are a few things. None of this is a contraindication, but certainly something I would certainly keep in mind in any patient that I would see. One final point I just want to say, though, about the lithium, no question, check your lithium levels closely in patients taking GLP-1s for the reasons I stated. Andy, we just published a study recently. It was a large observational trial, and we were able to show that we think that there may be some protective effects of the GLP-1s against lithium-induced nephrotoxicity. And that shouldn't be all that surprising conceptually, because they are already FDA approved to protect the kidney against diabetic injury. And there is some evidence that other nephrotoxic agents like tacrolimus, GLP-1s can protect the kidney. We don't have any histopathology evidence yet, so we don't know. But lithium, as you know, is the most effective mood stabilizer for many patients. And it's been ditched because of, part of ChatGPT and because of Dr. Gould, they don't like it. But it doesn't do good in public relations, that's for sure. But it's a fantastic drug. And I think we can rescue it for those people who would take it. If it wasn't for the kidney concern, that would be pretty cool. So we just published that, fingers crossed, that will be supported by some histopathology supportive evidence.
Yeah, that was a terrific article, and I've discussed it with our friend Jonathan Meyer, who, of course, published the Lithium Handbook, and he's very interested in that as well, because he's certainly invested in resurrecting lithium, if you will. And, talking about neuroprotective effects, I mean, there's a whole body of evidence on lithium and neuroprotection. So I think these issues you've brought up are all very, very practical. Really appreciate it. The idea that maybe they're not going to work for all conditions. The OCD was certainly fascinating. Of course, eating disorders. I want to go back to the suicidality for just a second, because you do hear this, and you also do hear that people kind of overdo the decrease in the motivation reward, anhedonia.
Oh, yes.
Some of this, I wonder if it isn't a dose-related phenomenon, much like the gastrointestinal side effects. I wonder if perhaps lowering the dose and trying to modulate motivation reward without overdoing it might be a prudent thing also. In my experience, people are very variable with respect to tolerability of these drugs. Some people just get incredible gastrointestinal side effects at lower doses. Some people can tolerate higher. So I think another important message is to really individualize your dosing. Would that be reasonable?
Completely reasonable. And you really brought up a nice point there, Andy. And some people have asked me, do GLP-1s cause anhedonia? And they hear from their patients that they feel flat, they feel blunted on them. A couple of reactions to that. I guess we've learned in psychiatry after decades, anything's possible. But I would say that typically, no, that's not typically what happens. remember that dopamine is tonic and phasic, and they don't typically reduce the tonic activity. What they do reduce is the aberrant phasic anticipatory activity, which is what you want them to do. You want them to tap the brakes when they're over craving a reward, like drugs, alcohol, food, and so on. That's what they're doing through GABA interneurons in the striatum. That's a good thing. That being said, I think that when patients do, I've heard patients tell me this too. I think there's a couple of formulations. I think first is probably most likely their baseline state. We're seeing them 5, 10, 15, 20 years after they started treatment. They're no longer using alcohol, opioid, drugs of all sorts, overeat. This is their baseline state. That's one formulation. But it's not meant to be diplomatic. I'll just maybe keep it brief that I think it is true. I think this is not, laser surgery. This is still, we have to be a little bit humble here. I think when you get into the reward area and you start affecting reward signaling, idiosyncrasies happen. And I do think some people, they could be promoting this blunted feeling, although I don't think that's what happens for most.
Yeah. Well, the motivation reward system, of course, it's like everything else. It's about modulation. It's not too much, too little per se. And so it seems to me it's reasonable to look at this more nuanced than just do they flatten people and cause it a dose. I have another question. You brought up the issue of these people getting things online, and I can't help but think about these TV commercials I'm seeing now about microdosing. What do you think of microdosing GLPs?
I suppose it's interesting because I don't think we still know what the minimal effective dose is. We in psychiatry spend more time talking about what's the maximum tolerated dose rather than what's the minimum effective dose. Those are two different questions. And look, in many ways, Mother Nature microdoses us. Natural GLP-1's only in your system for about maybe 60 seconds to 90 seconds. She is microdosing us. So I think it's an interesting question. I don't think we know what the microdose. I mean, we were hearing about people in part because of economics, spacing out the dosing intervals, things like that. It clearly is not known. There was a study done recently where people were taking medications more intermittently, and there was still some effect of doing that, but it was a bit mitigated. It's an open question. What does seem to emerge, though, Andy, this is the whole world of posology dosing, is the psychiatric dose, if it is a psychiatric drug, what's the dose? Is it the obesity dosing? Is it the diabetes dosing? Is it some other dosing? Don't know. But certainly, my own if I was to sort of say, where does the data fit now? This may change 2 years from now. It's closer to the obesity dosing, the dose a little bit closer, and for those less familiar, a little higher dosing. But I can't say that with a high level of confidence. I just say that with a low level of confidence.
Well, is it reasonable to assume higher doses might have some better brain penetration?
It's possible. It truly is possible. Or have greater effects on peripheral systems that then have a halo effect on the brain. For example, maybe it may not be necessarily causing more weight loss, although it is, but may have other effects on the liver, and that could be reducing also brain load. So it could be through those effects. So I think this is still a question we are scratching our heads on as to what is the posology, what is the dosing in psychiatry.
That's a fascinating concept, Roger, and the analogies that pop into my mind are differential dosing of SSRIs for depression versus OCD, and higher doses for OCD. Yeah, great point. Or atypical antipsychotics, higher doses are antipsychotic and manic, lower are depression. So that's a fascinating concept that the dosing might not be the same for all these indications. So a lot of research, a lot we need to learn about these things, of course. This has been a wonderful, wide-ranging discussion, but as we get close to wrapping up here, I just want to give you an opportunity to talk to our audience about how should they be thinking about these drugs? Should they be just welcoming them with open arms? Should they be thinking more carefully about them? Sort of where should they think about these fitting into our armamentarium?
Yeah, that's a great way to finish, Andy. I sort of see three categories for our colleagues listening in. I would say evidence-based on-label, evidence-based off-label, and aspirational. Those are the three categories. So evidence-based on label is there's 6 indications right now that every one of those 6 affects our patients at a much higher rate. And there's suspicion there'd be some other indications in the pipeline very soon, like heart failure with preserved ejection fraction as an indication, which would be the 7th, that also affects our patients at a higher rate. So that's evidence-based on label. Evidence-based off label, so to speak, would be to antidote clozapine weight increase or olanzapine weight increase. Crossing my fingers, though, don't know yet about the lithium, but we'll see where that goes. The aspirational is everything that you and I talked about. I'm hearing from colleagues across the country, around the world, saying, "Oh, I'm giving GLP-1s to help treat their alcoholism. It works great." That's still aspirational. And I think alcohol, tobacco use, opioid, others, depression, bipolar, schizophrenia, dementias, these are aspirational. And so I don't think we yet have enough evidence to say definitively whether they work there or not. Again, with that hopeful little carve out for alcohol, which is really ahead of the pack right now. So we'll see. So I think it's evidence-based on-label, evidence-based off-label, and aspirational. And all three tell me there's one word that I think comes to mind, and that's transformational. These drugs can really transform patients' lives above the neck, I hope, but certainly below the neck.
Boy, that is a wonderful formulation, Roger. I really appreciate that. And it's very pragmatic. And, what it points to is we do need more trials, more research. Of course, as you said, the gold standard would be your randomized, double-blind, placebo-controlled studies. Some of these studies, though, have to take a long time to see what we're looking for instance, cognition or relapse prevention. Some may not be as long. Perhaps we can show a signal on alcohol sooner than that. So we'll just have to see. But as we've said, Roger, do you have a sense of how many of these drugs are in development? Was I right when I said dozens?
It is dozens. In fact, to be exact, it's over 100. And people say, really, how many ways can you kind of slice and dice this? Well, people are, there's the single Gs, of course, like the single G meaning one of the, GLP-1, and then the Mounjaro type drugs, they're the double Gs. Then we have triple Gs, quadruple Gs, there's pentuple Gs, and then people are now adding other things to it, like amylin, which is another incretin. People may have heard about adding other molecules that protect the muscle against breakdown. They're even mixing GLP-1 with insulin together. So it's only limited by your creativity now, how they're being mixed together. And so that's why there's so many.
Yeah. Well, it's a very exciting time. I think transformational is a good word, and to bring it back full circle.
Yeah.
I want to congratulate you for being a voice in the wilderness there and for sticking with this.
It was lonely for a long time.
But I think you've had a major impact on our
that.
field for the better, Roger, and it's been just a pleasure and an honor to work with you. And I've enjoyed our conversation. Hope our audience has too. And I just want to wrap up by saying thanks, everybody, for listening. Hope this has been helpful to you, both pragmatically and also just optimistically and for excitement. And for more information about all of our educational offerings, our live meetings, our virtual Saturday morning live, even these podcasts, please go to our website, neiglobal.com. Roger, thanks so much.
Oh, thanks, Andy. A lot of fun.
Thank you for joining us for another episode of the NEI podcast. Please let us know what you'd like to hear more about by leaving a review. Don't miss another episode. Subscribe today. For more information about NEI and our premier educational content, please visit neiglobal.com.